Perfect. Okay, so welcome everyone to this evening's webinar around allergic conjunctivitis with Willis Wilkie, who is helping us out. He's been very involved actually in the writing of the PGD that has now become a national PGD. Although there is some news on that, we do actually have the PGD has come in from Scottish Government and it's going to the local PGD group for approval. However, we've been asked not to circulate it just yet because there is a negotiation going on at government level about the use of that PGD going forward and the other PGDs that we've got coming in for this summer. So hopefully that'll get resolved quite soon and we'll be able to send out the PGD. However, for those of you who are prescribers, then obviously you can start prescribing olopatadine now, and probably now's a good time to start. But I will not steal Willis's thunder by allowing him. Willis, do you have a presentation? I've not got a PowerPoint. I've only got the PDF. So I'm taking it you've got so do you want to just load that up onto your screen, and we can get cracking.
Does that work?
Okay. Yeah. We just don't see it in slideshow. We're just seeing all the slides at the moment. So you just need to put it into slideshow. That's perfect. Over to you, Willis. Thanks very much. And if anyone's got any questions, if they put them in the chat, then Lorna and I will look at that and we'll get to those at the end of the presentation. Is that okay? Right, on you go. Thanks very much.
Well, hi everyone. Thanks for coming this afternoon. Getting away from the sunshine. So I'm going to talk about allergic conjunctivitis, kind of presentation, management, treatment options, all that sort of stuff. So start off with the presentation. So this image that you can see here is kind of the classic acute
Willis, I can only see a black screen.
Oh, can you?
Yeah. And now it's a white screen.
Oh, that's weird. Let's see. So, you see it now?
I can see it now, yeah. It's just not in the slideshow, it's just your slides. But yes, you can see it.
Is that the slideshow now?
Not yet.
Okay. There's a slideshow on mine. So is that showing yet?
That's gone to the next the next slide. So I mean, if you want to just do that, could you maybe make your screen a bit bigger? That would be I think that would do. That's perfect. Thank you very much.
Okay. Yep. Thanks for that. So I don't know why that's not working, but so I'll start with the presentation, which is the kind of main part of all of this. So this is what an acute allergic conjunctivitis would look like. So this is quite a severe looking eye. Patient will be relatively worried about this, and these ones that come in need a slightly different type of treatment, but I'll kind of move on from that. So your classic allergic conjunctivitis, it's all about the time of year that it happens. So we're right in the midst of it at the moment. So patients will be coming in with a kind of classic presentation of bilateral eyes are red, they're itchy, slightly swollen, and there's a kind of pinky red appearance to the conjunctiva with potential chemosis, which is that, if you look at letter C down there, that sort of swelling to the white part of the eye. That's chemosis. Sometimes they'll have that, sometimes they won't. There can be swelling to the lids and a watery discharge, and obviously the nose can be going as well. Onset, like I say, will be seasonal or perennial. Symptoms, the biggest thing is the itchiness. So the patient will come in complaining of itchy eyes, slight irritation, pain and photophobia are not usually present with this. The vision might be affected, but it's only because of the discharge that's coming from the eyes. So treatment options. So we've got a couple. Off the bat, what you should be looking for is identifying the allergen. So like I say, this time of year is quite easy. Patients should have probably noticed over the past couple of weeks that their eyes have just not felt right, irritation, watering, and that would give you an indication that this is most likely an allergic reaction. So the general advice is trying to avoid the allergen. At this time of year, you can't really do that. Cold compresses can give symptomatic relief just from swelling and the itchiness, and advise against rubbing the eyes because that causes the mechanical mast cell degranulation, which causes everything to get worse. So the kind of first line treatment is sodium chromoglycate, which is Opticrom. It's available to anyone to prescribe. You don't need a prescription. It acts as a mast cell stabilizer, so it has a more delayed effect on resolving the symptoms. So if you're prescribing this, what you want to make sure you tell the patient is you need to stick with it. Using it 4 times a day, potentially for a week or two before it'll start to have an improvement in the symptoms. So a lot of patients that I see will come and say, I was given this, and after 3 days it's made no difference, so I stopped using it. And with that, it's just about instructing the patient, this won't make an immediate effect. What you're hoping for is that over a week or two, their symptoms start to get better because that's when the drop starts to work. So they're going to use this 4 times a day. Children and adults can have it. It contains a preservative, benzochlorine chloride, which can start to cause an irritation. So if the patient has been using it and it has been working, but then they start to have gritty or irritated eyes, it could be because of the preservative that's in it. The next option, which is the big one, is olopatadine. Obviously, pending the PGD, IP optometrists, pharmacists, and GPs can prescribe it. So this one acts as a selective antagonist to the histamine HA blocking receptor, and it also has mast cell stabilizing agents in it as well. So with this, it has a much more immediate effect for the patient. So maybe within the first hour, they should notice that feels better. But really for you, what you can do is you can give it to the patient. Within 2 to 3 days, they should start to notice an improvement. And if they're not, then that gives you an indication that this might not be allergic. So the dosage for this is twice a day, maximum for 4 months, and that's just because all the trials and all the data that's on it is only for 4 months. But that means you can stop it for a couple of weeks and then restart it again. There's no issues with doing that. It's not suitable for children, again, just because the trials didn't include younger children than 3, and also it contains a preservative. So the other thing to think about with the preservative is if the patient uses contact lenses. Olopatadine works really well because it's only twice a day, so the patient can use it in the morning and at night just before they've put their contact lenses in. If they use it with their contact lenses, what you find is that preservative gets into the contact lens and can give them some real wearing issues. So in association with the anti-allergy eye drops, consider artificial tears. Carbomer gel, Clinitas will work quite well. They can use that 2 to 3 times a day. Keep it in the fridge. Will also make it a kind of soothing agent when they put it in. And it also acts as a barrier and a diluting agent to the allergen. If it's not fully resolved in 5 days, don't be too concerned with that. What you should be looking for here is an improvement. Patients should be coming in saying, that's worked, but it's not gone. And as long as they're saying that, then you know this is kind of doing what we're wanting it to do. So in conjunction with your olopatadine, you might start to introduce an oral antihistamine, cetirizine, loratadine are all available in pharmacy first. Hexafenadine a little bit stronger, and for the patient it can be a little bit more expensive. And if you're wanting to supply these over the summer months, then again, IP, optometrist, pharmacist, or GP will need to be contacted. There's other topical preparations, which is the Otrivine antihistamine. It's very rarely used. I don't use it at all myself, but you should be aware that it's also there. It has some antihistamine H1 blocking properties, so again, should give a little bit more of an immediate relief for the patient. So the next bit is the differential diagnosis. So how do you know it's allergic conjunctivitis? Again, there's kind of 3 different types of conjunctivitis: viral, bacterial, and allergic. With the viral conjunctivitis, what you find is quite different. It will have started in one eye, be quite bad in that eye, and the patient might have more pain and photophobia with this one because the cornea can be affected. The discharge will be watery, there might be some slight swelling to the eyelid, but usually the other eye will become affected 2 to 3 days later, but not quite as bad. So with this, the history and symptoms that you take from the patient is quite important. They'll either have had a cold, upper respiratory tract infection, feeling run down, and that's maybe they're feeling better and then their eyes start to go. that would give you an indication that it could be this. Bacterial conjunctivitis is quite classic. It's just the discharge you're looking for. So it'll be a yellow, green, white discharge, which just constantly keeps coming. One eye will be affected, and then very quickly the other eye becomes affected. With this in adults, it should be relatively rare. So if it's happening, then you're thinking that they either work with kids or they have young kids, and that's where they've got it from. Other differential diagnosis is kind of more severe or more serious eye conditions, which can always have a bit more pain, photophobia, and their vision's affected. If the patient's mentioning anything like that, then it's not allergic conjunctivitis that they've got. And with these things, referral to an optometrist would be warranted, because they might have corneal ulcers, anterior uveitis, or a closed-angle glaucoma attack. These are rare, but it could be something like that. And you would know, again, from the history and symptoms in the presentation, that it doesn't sound like something they've had for 2 to 3 weeks that stayed about the same. Finally, preorbital cellulitis and orbital cellulitis. Again, this can cause a swelling to the face, but it would maybe have started with maybe a sty that seemed to have gotten worse. There'd be a lot of pain and tenderness to the lids, which you don't get with allergic conjunctivitis. There's swelling, but there's no real feeling to that. And with this, it would, like I say, it's a gradual onset that seems to be worsening. Redness and tenderness to the lids. They would have a pressure, obviously, when they bend forward. They feel a pressure on the front of their head. And if they're feeling unwell or a fever's developed, then it's a bit more serious. Again, a referral to an optometrist would be the thing to do. So that's pretty much me. So I'll take any questions if you've got any.
So thanks, Willis. It's always very, it's always very clear, and it's. I mean, see the viral conjunctivitis. There's nothing that we could suggest. Is it just symptomatic management?
Yeah. So with viral, what I find is if it's non-corneal and like there's no corneal involvement, then what you find is a lubricant that they can keep in the fridge and cold compresses will make them feel better. So with this, you're just saying, look, you're going to get this for a week to 10 days, maybe 2 weeks. And all this is about is just making you feel better. These drops won't get it away any quicker, but you'll just feel you can manage it a bit better. So patients will usually be like, I'm on my computer screen or I'm working and I feel that my eyes are really annoying me. And all you're saying is these things that we can do will make you start to feel better.
That's brilliant. So we have had one question so far from Sima. She knows, does an IP need to sign a PGD for olopatadine? And the answer is you can use the PGD if it's under the Pharmacy First service, or you can write it on a prescription. It's really up to yourself. As I said at the very beginning, the PGD, although we have it, we're not actually circulating it at present until we are hear about the negotiations. And actually, Willis, we've also got a PGD coming for fexofenadine, so that will also, so that's part of there's 4 PGDs that are coming in, which includes 2 nasal sprays and fexofenadine and olopatadine. So once they are released, then it'll give people another option. So basically, you can sign the PGD and you can supply under Pharmacy First. But if you're an IP and you want to prescribe, then that is also totally appropriate. So that was the question from Simon. Does anybody else have any other questions for Willis about eye presentations? Lorna, do you just want to tell Willis the question?
Yeah, this was a question that was emailed in for someone who couldn't attend today, and they have a patient who's about 1.5 years old. They are currently taking Piriton chlorpheniramine, but their main symptoms are eye symptoms, and the pharmacist was asking, they'd mentioned about sort of doing washes and trying to keep the eyes clean, but are there any eye drop options? They had thought there weren't, but they thought, but as we could ask the expert, that we could ask yourself.
Yeah, so I guess your issue is it licensed for the child? And there's not many. I think, like I say, for sodium chromoglycate, it doesn't say an age, it just says children. So I couldn't find anything on that would say that you couldn't. With 1.5-year-olds, it's more about trying to put drops in. they're not really going to be very cooperative with you. So, I mean, the first thing to probably try is like a preservative-free blink intensive eye drop. Keep it in the fridge and put that in and see if the child will allow you to do that. If you can get some symptomatic relief that way, great. Cold compresses, again, will make a bit of a difference. But I think if you really wanted to prescribe something, sodium chromoglycate you would do, but you're going to have to do it 4 times a day for a couple of weeks before they're going to get any sort of symptomatic relief, and it's going to have to continue on. So, while you can technically do it, I mean, trying to get a kid to put in chloramphenicol for 7 days is like an absolute nightmare. So I don't think any parent would thank you for giving them drops that they have to continue to use. So it's a bit of a tricky one. I would start with preservative-free eye drops because they won't nip, and if they're cold and soothing, you might get away with it.
Okay. Is there a follow-up, Lorna?
Well, I was just checking back. So quite often of a weekend, there's a bit of buzz around the pharmacy WhatsApp. So I was just checking back because there had been a couple of different queries. So this was one that we had a few weeks ago, and I'm not sure. I don't think Nadia is on the call, so we don't know what happened next steps. But it was a patient who was 30-year-old with ongoing conjunctivitis despite 5 days treatment with chloramphenicol. It looks as bad as it did initially, she had said, and would be advised to continue with the drops. I think the vast majority of people who answered had said maybe send them to an optometrist, and Mary Ann had mentioned about maybe sending to the practice nurse in case they needed to swab for sensitivities. So it was just maybe just checking if that was the kind of right advice that people had given.
Yeah, I would say that's the right advice. For us, if we went to optometry, we would just be checking that that's what was going on. Anything that's lasting that amount of time with an antibiotic, then you're thinking it's not bacterial conjunctivitis, because within about 3 days you're starting to see an improvement. I think, yeah, you're probably, if it came to us and we weren't sure, we'd be sending on for a swab. So I think either of those two things would be right.
Okay, thank you for that. So we've got a question from Kirsty. Is it common to get moderate swelling and redness around the eye with viral conjunctivitis?
Yeah, I mean, they're all quite different, but with that, it would be, I guess, it's what you say is moderate swelling. So usually it would just be like the top lid can have a little bit of, I say a little bit of swelling. It's not like that image that I had at the end, which I would say is kind of moderate to severe swelling. If you're talking about that, you shouldn't really get that level with viral conjunctivitis. You can get a little bit, but not that much.
Okay. And then Simon, you've asked a question about what are is it the Pharmacy First refrigerate eye drops? I'm not quite sure.
Preservative free.
Preservative free.
Oh, preservative free. You see, initial, all these initials are too hard for me. So yeah, so what are the preservative free eye drops?
So there's a couple, I think they're on the formulary. So you've got Blink Intensive, IA's 0.4%, and Theolose Duo. So what you could, I think also Pharmacy First has a carbomer gel as well that you can use.
If you can get it, yeah.
If you can get, I was going to say, because that was, yeah. I'd say Blink Intensive 0.2% eye drops. They're preservative free, and you can just keep them in the fridge. You don't need to, but like I say, when it's this time of year and it's a bit itchy, the coldness kind of helps.
Sounds lovely, actually. I was just thinking, nice wee cold compress from time to time would be lovely. So, does anybody else have any other questions for Willis?
Or if you get anything that people have walked into the pharmacy and you've directed them on and wonder what happened, or anything you've had recently that's presented that's maybe flummoxed you a wee bit, and you can ask if what you did was the right thing to do. This is your opportunity to do that.
Go for it.
While we're waiting, it's also an option for pharmacists now. If the community optometrists are not open, and if they're closed, you can also refer people with an acute eye problem to the FNC, which I sent information out about last week. in the newsletter update. So that allows you to refer direct to them, and they have direct access into various eye clinics. So they themselves wouldn't, they would triage the patient, and if they felt the patient needed seen, they can direct them into the acute sector eye clinics. So that's another option when your friendly community optometrist is not available for any reason. We're just getting a thanks. So from Ashley, thank you for your presentation. Using carbomer together with antihistamine drops, what would the dosage regimen be, and what would there have to be time between so you don't dilute the antihistamine? So, when would you take, what order, and how long between?
Yes, that's a good question. You would use the antihistamine eye drop first thing in the morning, and then you want to at least give 5 to 10 minutes between using the other drops. Because the carbomer gel is thicker, you always want to use that the last, and use that, I would say, 3 times a day during the day. So olopatadine in the morning, and then maybe give it an hour and start using the carbomer gel. And like I say, the patient can use that as much as they wanted to if they're getting symptomatic relief from it. But just give a 5-10 minutes between using the drops if they were going to use them at the same time.
Okay, it's always that practical thing that, it's always really useful to know what to do in which order, because sometimes it's not that obvious, So yeah, thank you very much for that. And Ashley is thanking you. Is there any more questions? Oh, here's one coming in. From Amna, I spoke with a local optometrist who was discussing about the difficulties patients were facing with referral forms for GPs, in which the optometrist was recommending a prescription-only eye drop, such as Theolos Duo or Carmelo's unit dose. Is that something we can prescribe in collaboration with optometrist referral forms? So are you talking about being an IP, Amna, or are you talking about being a pharmacy first? If you're an IP and you're happy and you want to prescribe in conjunction with a non-prescribing optometrist, because obviously we have optometrists who are also prescribers, then I would say yes. Yes, being an IP. So absolutely. I mean, and I think actually that's a really good combination. You've got an expert there who is giving you a recommendation, and if you're happy to accept that recommendation and then prescribe, then I don't see that being a problem. So, Willis, you would be happy with that, wouldn't you?
Absolutely. I think what we're trying to make sure, especially for non-IP optometrists as well as IP optometrists, that they're using the formulary, because it's changing a lot. So it's knowing, like Hilo 40 just came off it and Theolos Duo is now on it. So it's kind of, if it's coming to the pharmacist and you're thinking that's not on the formulary, I would take that opportunity to speak to the optometrist to make sure they're aware, because your recommendation will be just as good because of the options that we've got.
Yeah, I like that. Stick to the formulary, please.
Yes.
And then it stops Lorna and I coming round to tell you off when we're doing your prescribing visits. Yeah, to Taisha, yes, this is being recorded and we will share the link after, assuming that it's okay because Lorna pressed record, so she'll be able to share that link, so that'll be fine. And Mariam's asked, for bacterial conjunctivitis, when do you recommend starting chloramphenicol drops?
So that's a good question, because I just tell the patient what to expect from it. So like I say, I get a lot of kids with bacterial conjunctivitis and I'll be like, you don't really need to be using it. Okay, it's not too bad. It's self-limiting. You're taking it from being a 5 to 7 day or a 10-day thing to a 5 to 7 days. And you need to use it once every 2 hours for 2 days, then 4 times a day for 5 days. And with that, I think you just need to reassure the patients or the parents, because they're like, oh, this looks really bad. Keep it clean and your child will be fine. For adults, if they've had it for a couple of days, then again, I'm saying, look, this will take about 3 days to work. So depending on how bad it is, there's a lot of discharge and it doesn't look that comfortable for the patient. That's when I'll usually start it. But I kind of leave it on the patient to decide, yes, I want to do that, or no, I don't want to do that.
Okay, and certainly with the frequency that you have to use them, at least to begin with, it is very challenging to do it properly, isn't it? Kirsty has asked a question about any recommendations for an IP pharmacist's prescribing for babies with bacterial conjunctivitis, like for a minimum age. They're aware that there are some differentials within the first few weeks after birth.
Yeah, so that kind of first few weeks, if they've got a conjunctivitis, you've got to treat it as quite a big deal. So don't get involved in those ones. You want to be speaking with the relevant kind of healthcare professionals for those. If they are a bit older than that, then again, I wouldn't prescribe most of the time, because of, like I was just saying. So I would just be keeping it clean. Sometimes with newborns, the drainage canal into the nose hasn't fully formed yet or opened up. So they can have an ongoing conjunctivitis that happens, goes away, happens. And with that, again, it's just a case of reassuring the parent this is normal, keeping it clean and just massaging it there can sometimes spontaneously open it, rather than giving, the child another wave of antibiotics after antibiotics. So that's usually I don't think since I've become IP I've prescribed chloramphenicol for anyone under 2.
Okay. Fantastic.
Yeah. I think sometimes there's, I don't know if it's still the case, but when my kids were in nursery, it was they can't come back to nursery until they've had their eye treated. So I think sometimes that can be a wee bit of a pressure for people as well. But
Absolutely.
yeah, I think if they're so comfortable, just try and keep them off nursery maybe. But yes, I suppose for some people it maybe they have to send them. But
absolutely.
Okay, so any other questions? I think it's been a really interesting and informative evening, and it's always good to have an expert on hand to answer these types of questions. And this is being recorded, and then anybody who has been unable to watch it live can also see it back. So I think with it, that's past. So I think it, seeing as the evening is so lovely, if anybody would like to get out and enjoy the late evening sunshine, I think we'll bring this to a close. So can I just say thank you very much, Willis, as always, for being very helpful and very supportive of community pharmacy.
Okay.
We appreciate that. Thank you to Lorna for helping me out with my IT failings. And I think with that, I'll just bring the meeting to a close. Lorna, do you want to just press the unrecord button or the stop recording button or whatever button we have?